Now coming to the physiology of labor and certain normal terms which must be known like false labor, pre-labor, true labor, lightening, etc. So let us begin with false labor. It is also called as spurious labor and it is found more commonly in primigravida compared to paras women. It usually appears prior to the onset of true labor pains by 1 to 2 weeks in primi, or it actually accompanies the labor just before a few days. You can have false labor in multipari and finally it terminates into true labor. What is the cause of false labor? It is because of stretching of the cervix and stretching of the lower uterine segment. Now, when we talk of false labor pains, they have certain characteristics. So, false labor pain is dull in nature. It is confined to the lower abdomen and the groin. It is not associated with hardening of the uterus or uterine contractions. There are also no other features of true labor pains. For example, presence of show or formation of bag of waters. They are typically not mounting in nature. That means there is no incessant increase in the intensity, the frequency and the duration of the uterine contractions. And false labor pains are usually relieved by enema or sedatives. So if you have all of these characters, pain which is dull in nature, which is confined to the lower abdomen and the groin, which is not associated with hardening of the uterus, there is no show, there is no formation of bag of membranes, which is usually relieved by enema or sedatives, and it is typically not mounting in nature. That means it is variable in intensity, duration and frequency. It is most likely a false labor pain. Now we have another term that is pre-labor. It is also called as the premonitory stage of labor. The premonitory stage usually begins 2 to 3 weeks before the onset of true labor in primigravida and only a few days before in multipara. So what happens in pre-labor? We have cervical changes and the appearance of false pain. I've already told you the characteristics of false pain, and we will learn to differentiate false pain from true labor pains. So what happens in cervical changes? A few days prior to the onset of labor, the cervix starts to become ripe, and this is known as the process of cervical ripening. If we look at a cervix that is unripe, it is usually considered as firm as the consistency of the nose. So it is firm. The location of an unripe cervix is usually posterior. It is also undilated and uneffaced. Now, what do I mean by ripe cervix? It becomes soft and typically the consistency changes from being as firm as the nose to as soft as the lips. There is also an effacement in the cervix. That means there is taking up of the cervix, and this is manifested objectively as a decrease in the cervical length. So if you look at normal cervix, it is 3 to 4 centimeter in length, and with progressive effacement or taking up, it becomes less than 1.5 centimeter in length, that is equal to or more than 80% effacement is seen. What about the dilatation? It easily admits one finger, and cervical canal is also dilatable on examination. So both of these factors, that is presence of cervical changes, which refers to cervical ripening, there is a soft cervix, effaced cervix, which admits one finger easily, and there is a concomitant appearance of false pains, and these are characteristics of the pre-labor or the premonitory stage. Remember, both of these changes are pronounced earlier in cases of primiparas and later in cases of multipara. Now, there is another term which we must be conversant about, and that is lightening. So, weeks prior to the onset of labor, especially in primigravida women, the presenting part sinks into the true pelvis. And what is the reason? There is active pulling up of the lower pole of the uterus around the presenting part. So, the woman feels a sensation of lightening, and the reason is sinking of the presenting part into the true pelvis. This diminishes the fundal height and it minimizes the pressure on the diaphragm. So the mother experiences a sense of relief from the mechanical cardiorespiratory embarrassment. So what happens if we chart the fundal height? So here is the umbilicus. This is at 32 weeks. This is at around 36 weeks. And when the woman becomes 38 weeks in gestation, we are talking about a primigravida, the symphysiofundal height again decreases. So this decrease is because of sinking down of the presenting part into the true pelvis. So what will be the clinical manifestations? There will be a decrease in the symphysiofundal height. And when you ask about the symptoms, because the pressure on the diaphragm is reduced because of going down of the presenting part, she experiences a sense of relief in the mechanical cardiorespiratory problems. So she has a better time with respiration, and the difficulty which is usually there, or the discomfort which is usually there because of diaphragmatic pushing, goes away. Now, why do we focus on asking about lightening before even doing the clinical examination? Because lightening is a welcome sign as it rules out cephalopelvic disproportion and other conditions preventing the head from entering the pelvic inlet. So, if you have the presenting part sinking into the true pelvis, there is a high chance that the pelvic inlet is adequate, and we can clinically rule out cephalopelvic disproportion at the level of the inlet. It also tells you that the fetal head is bound to be well flexed, because if the head was deflexed, this sinking down does not happen and the presenting part does not sink into the pelvis. What about other conditions? So, if there is placenta previa, if there is a malpresentation, or if there is maybe a fibroid at the lower pole of the uterus, in all of these conditions, this lightening sensation is not felt because the presenting part fails to sink deep into the true pelvis. So, whenever we have the symptom of lightening, especially in cases of primigravida, it helps us rule out cephalopelvic disproportion at the level of the pelvic inlet. So, this is how lightening looks like. This is the pelvic brim or the pelvic inlet. The baby is right above the pelvic brim and close to 37 to 38 weeks of gestation in a primigravida woman. The presenting part sinks down into the true pelvis, and there is a concomitant reduction in the symphysiofundal height. Also, the respiratory discomfort because of pushing of the diaphragm is reduced. Now, coming to true labor pains, we have already discussed the features of false labor or spurious labor pains. When we look at true labor pains, they are painful uterine contractions occurring at regular intervals. That means there is a certain rhythm to the uterine contractions. The frequency, the intensity, and the duration of the contractions keeps on increasing progressively, and this is known as the mounting nature of the uterine contractions. So what usually starts as mild uterine contractions finally becomes adequate and it is considered that if you have equal to or more than 3 uterine contractions, each lasting for 40 to 45 seconds in a 10-minute duration, this is considered as adequate uterine contractions. So the uterine contractions are painful, they are at regular intervals, and there is increasing frequency, intensity, and the duration. True labor pains are also associated with show, which is bleeding mixed with cervical secretions. On vaginal examination, in case of true labor pains, there is progressive effacement as well as dilatation of the cervix. So, true labor pains are associated with cervical changes such as dilatation and effacement. Now, the presenting part also keeps on descending. So, with advancing labor, you can have a progressive descent of the presenting part. True labor pains are also accompanied by formation of the bag of four waters. And what happens here? Supposedly, this is the baby. This is the head of the baby. We have the amniotic cavity divided into two compartments. There is prolapse of this bag of four waters right in front of the presenting part, and behind it we have the hind waters. So, if you have the bag of four waters which is forming, it is a characteristic of true labor pains. And finally, true labor pains are not relieved by enema or sedatives, unlike the false labor pains. So, what are the characteristics? You have painful uterine contractions, which are regular. There is increasing frequency, intensity, and duration of contractions. They are associated with show. There is progressive effacement and dilatation of the cervix. There is also progressive descent of the presenting part. There is formation of the bag of four waters, and true labor pains are not relieved by enema or sedatives. If you look at the distribution, so you have pain starting in the back, and this progresses to the front, involving the groin, the lower abdomen, and even the thighs. So the characteristic distribution of the pain also tells you whether it is false labor pain or true labor pain. So true labor begins in the back and it radiates to the abdomen and the thighs, whereas false labor is felt only in the lower abdomen and the groin. If you look at the regularity, the contractions in true labor are regular, rhythmic, and progressively stronger, both in intensity and duration, and the frequency also keeps on rising. The false labor contractions are irregular and they are variable in intensity. Now, what about the interval between pains? So, it becomes shorter over time. That means the frequency keeps on increasing. In case of false labor pains, the interval remains long or it can be irregular, but there is no specific pattern. The duration is increasing in case of true labor and usually it remains short in case of false labor. Now, what is the effect of activity? So, the true labor pains persist or may worsen with walking, whereas false labor pains can subside with change in position or rest. Even if you give enema and sedatives, the false labor pains tend to subside, but the true labor pains persist even after enema and sedatives. Coming to cervical changes, there are no significant cervical changes in cases of false labor, but we have a progressive effacement and dilatation of the cervix in cases of true labor. What about membranes? So, in true labor, you have formation of the bag of waters. In case of false labor, there is no such bag of waters and the membranes are intact and they are well opposed with the presenting part. We usually have the presence of show in true labor, but it is absent in cases of false labor. The contractions in the uterus are coordinated, strong, and mounting in nature in true labor, whereas they are weak and poorly coordinated in the rhythm and the rate in cases of false labor. So these are the key differences between true labor pains and false labor pains. Now we also have another term, that is Braxton Hicks contractions. So let us learn what are Braxton Hicks contractions. Throughout pregnancy, there is presence of painless but palpable contractions, and these are called as Braxton Hicks contractions. There is simultaneous hardening of the uterus, which is palpable by the clinician. So these painless but palpable contractions where there is hardening of the uterus throughout the pregnancy are known as Braxton Hicks contractions. Now these Braxton Hicks contractions change their character and they become more powerful, intermittent, and get associated with pain close to term or close to the onset of labor. So this pain, which was initially felt in the hypogastric region, now also extends towards the thighs. So Braxton Hicks contractions are painless and palpable to start with, but with the onset of labor, closer to term, they change their character, become powerful, intermittent, and also become painful. What is the location of this pain? It is restricted to the front of abdomen, mostly the hypogastric region, and it can radiate towards the thighs. So these contractions are the contractions present in cases of false labor at the very beginning, where they are initially painless, irregular, and later on become painful. There is no associated cervical dilatation, and Braxton Hicks contractions, they are noticeable in the third trimester, but they are not associated with true labor. What are the key features? If we look at the nature of the contractions, Braxton Hicks contractions are irregular, infrequent, and non-rhythmic. They are painless and palpable to begin with, and later on, when these merge with false labor pains, they start to become painful. What about the intensity? There is a mild discomfort because of hardening of the uterus, but usually Braxton Hicks contractions are painless. Now, when they merge with false labor pain, where the woman feels the pain, it is felt in the abdomen or the groin, but not the back. So, this is a characteristic feature because true labor pains usually start in the back and then they progress to the front, that is the abdomen and the thighs. Now, what is the effect of movement? So, Braxton Hicks contractions may go away with rest, hydration, or a position change. There is no effacement, no dilatation of the cervix. They are common after 28 weeks of gestation and they are more noticeable in the late third trimester as term approaches. The duration is also short, usually less than 30 seconds, and these contractions do not progress to true labor. So, Braxton Hicks contractions can be felt by women in the late second and the third trimesters because of simultaneous hardening of the uterus. You must reassure them, ask them to rest, hydrate themselves, do a position change, and this can go away easily. Now, let us understand what is show. With the onset of labor, there is profuse cervical secretion from the cervical glands. Simultaneously, there is slight oozing of blood from rupture of capillary vessels of the cervix and from the raw decidual surface caused by separation of the membranes due to stretching of the lower uterine segment. So that is why the cervical secretion from the cervical glands along with blood, which is coming from two sources. One is rupture of the capillary vessels of cervix, and the second source is the raw decidual surface caused by the separation of membranes due to stretching of the lower uterine segment. So, expulsion of cervical mucus plug mixed with blood is known as show, and this is also a sign of true labor pains. Next is dilatation of the internal os, because I told you cervical changes like dilatation and effacement both are characteristics of true labor pains. So, with the onset of labor pain, the cervical canal begins to dilate more in the upper part than in the lower because of corresponding stretch of the lower uterine segment. So, when contractions start to begin in the upper uterine segment, the lower uterine segment undergoes a receptive relaxation. It starts to increase in length, and because of this, there is a stretching effect on the cervix. Now, in cases of labor, the cervical ripening has already happened, and this is why a soft cervix starts to begin dilating. So, here we have an uneffaced and an undilated cervix. Here we have a fully effaced cervix. That means the cervical length is shortened to maximum, but it is only 1 centimeter dilated. And here you can see a fully effaced and a fully dilated cervix up till 10 centimeter. So, when we look at the dilatation of the cervix, a 10 centimeter dilatation is considered as full dilatation of the cervix. When we talk about effacement, we can do it in percentage, like 20% effaced, 50% effaced, 70% effaced, 90% effaced, etc. But it is subjected to intra and inter-observer variation. So, instead of effacement, now we talk about the cervical length. Usually it is 3 to 4 centimeter, and it starts decreasing, and when it becomes less than 1 centimeter, that means there is satisfactory effacement of the cervix. Now, this change is also there when we talk about Bishop scoring. So, in the original Bishop score, in the cervical characteristics, effacement was used, but in the modified Bishop scoring, for a more objective assessment, instead of the cervical effacement, what we use is cervical length. Both of these processes, they usually go hand in hand, but then there can be a disparity as well. So, here you see that the cervix is fully effaced, but only 1 centimeter dilated. Or you can even have dilatation of the cervix, but the effacement is lagging behind. So, multiple permutations and combinations can happen. The next sign of true labor pains is formation of the bag of waters. What happens? Because of stretching of the lower uterine segment, the membranes are detached easily because they are poorly and loosely attached to the decidua. So, in the lower uterine segment, there is an easy and early detachment of the fetal membranes. With progressive dilatation of the cervical canal, the lower pole of the fetal membranes becomes unsupported, because now what is happening? The lower uterine segment is stretching and the cervix is also shortening. With dilatation, the lower pole of the fetal membranes becomes unsupported and it bulges into the cervical canal. So, this is how it looks. So, we have a well apposed presenting part, that is the fetal head, with dilatation of the cervix and with stretching effect of the lower uterine segment. What happens? The support to the fetal membranes is gone. So the membranes start detaching in the lower uterine segment. They start to bulge in front of the presenting part, and this is known as the bag of four waters. So this bag of waters or bag of four waters appearance is almost a certain sign of labor, and it tells you that the cervix has started to dilate. So we have four waters in front of the presenting part and we have hind waters, and these four waters are also involved in the mechanism of labor because they give you an axis pressure in order to dilate the cervix further. So we have learnt about the types of contractions, the Braxton Hicks contractions, differences between true labor pain and false labor pain. We learnt about what is show, expulsion of cervical mucus plug mixed with blood. We learnt about the dilatation of internal os because of corresponding stretching of the lower uterine segment. Then what is the difference between cervical effacement and dilatation, and the formation of bag of four waters, which is almost a certain sign of labor.